Hi, my name is David Morton, and I'm a professor of neurobiology from the University of Utah School of Medicine. And today I'm going to talk about the anatomy of the respiratory system. Why do we need the respiratory system? Well, something that you already know before you started watching this video is you inhale and you exhale. And you inhale oxygen and you exhale carbon dioxide. Now that oxygen needs to get from inside our respiratory system to every cell in the body. That's why the cardiovascular system, our heart, arteries, veins, and capillaries are so important. So today I want to talk about how we get air in, what happens to that air, and then how that gas exchange occurs very deep inside the lungs. So in this illustration, it shows we're going to go over some of the parts of the respiratory system. To start with, these are upper airways. Now, in the upper airways, this is going to then go down to our larynx, and then our larynx or voice box is going to go down into our trachea. So let's take a look at this. This is called a mid-sagittal section of the head. We take a section right through here, separate our heads into left and right, and then we take a look at an inside view. In this, there's our nasal cavity. We've got these little ridges, these three ridges called nasal conchae. And they're called that because they just look like a conch or shell. And they swirl the air as we inhale it inside our nose. And there are these tiny hair cells that line that kind of pick up little dust particles that are inhaled. And plus we have these cells called goblet cells that secrete mucus. Think of it like flypaper, where sand and particles, I said sand, probably more like dust, particles coming in and they stick to the inside. And then occasionally you'll blow your nose and get rid of all that. Also lining this nasal cavity are blood vessels that warms and moistens air as it comes in. Next we have our oral cavity. So this is the part that shares with the digestive system. You inhale and exhale air either through your mouth or through your oral cavity. If you inhale through the mouth, also lining the inside of your cheeks, lots of blood vessels that warm and moisten the air. At the back, we call this the back of your throat or the pharynx. And the pharynx goes from the nasal cavity, oral cavity, and right down by your voice box or the larynx. And this is also shared between digestive and respiratory systems. So what we need to do is do something to ensure that food goes down your esophagus and air goes down your trachea. So this structure, this is elastic cartilage, this little structure called the epiglottis, is going to help us make sure that air goes down the trachea and food goes down the esophagus. So watch this epiglottis when we swallow food. Okay, you see how it goes almost like a trap door. And so the food particle is going to be going down the esophagus and we close off the airway. Primarily because if you put air down the esophagus, like in someone's doing forced CPR and breathing inside and air goes down the esophagus, it fills the stomach, and what happens is someone just vomits after that. But if you put something down the trachea, like a piece of food, and it clogs this area, air cannot get in or out. So this is very important, and this is why this part right here, this is called this is the vocal folds, and the space between them is called the glottis, has a very important function. So this is an anterior view of your thyroid cartilage or the Adam's apple right here. And if you touch that and then just hum, touch this and go, and if you hum, you kind of feel that it vibrates because directly behind this, there are these vocal folds. And these vocal folds open and close. And the opening and closing is what allow us to make sound, or one of the many things that help us make sound. So if you ever have that annoying person at a birthday party, they blow up a balloon and then they take the top and they squeeze it and it goes, ee! It makes that really annoying sound. That's kind of how our vocal folds work, where air rushes through and those folds vibrate, and based upon how wide or narrow that opening is, and based upon how tight or loose those vocal folds are, changes volume and pitch in making a sound. And that space that you see right here, this is called the glottis. And the epiglottis is this connective tissue or this cartilage above it. If something blocks this, then a person can't breathe. So nature has made this so that we've got a very strong reflex. And a reflex is something that that there are some reflexes that you can override consciously, like your patellar tendon reflex, where the doctor takes a hammer and hits your knee and your knee jerks. And there's some reflexes that you do not have conscious control over, and this is one of them. So the cough reflex, and have you ever had this where you say you're talking with a group of friends and you drink something and it goes, and you laugh and it goes down, you hear it goes down the wrong pipe, and then you go, and then like almost immediately you've got milk or soda coming out your nose. Because anything that touches the top of this elicits immediately a reflex to get it out of that area, to immediately project it out by air forcefully coming up through the trachea where the diaphragm contracts and forces air out. That cough reflex is very important to try to help us to stop from suffocating. Or if something does get blocked in there, you may have heard the Heimlich maneuver where someone grabs you from behind, squeezes, you're basically forcing air up to do your best to dislodge the food that's blocking it. So the trachea is this tube, and the trachea, your windpipe, often people call it, is this tube that connects the larynx down to your bronchial tree, the airways that will go into your lungs. And so part of the skeleton of this, and I use that word skeleton not so much for bones, but the structure, we have these C-shaped cartilaginous rings. And they're C-shaped because they're the letter C, except they're horizontal. And they form this front framework of the trachea, but behind the trachea, as I showed, is the esophagus. So there's this opening so that as food moves down the esophagus and pushes into the back of the trachea, you can still have that flexibility, but the trachea is still strong. And part of this is the upper airways, like the trachea and the proximal part of the bronchial tree. We need to help make sure that those airways do not collapse whenever you exhale. An example, if you take a balloon and you blow it up, and you've got the end, and then you let go, the air goes out, and that balloon collapses upon itself. So to help ensure that our airways do not collapse upon themselves every time you exhale, the trachea and the proximal part of the bronchial tree that we'll see down the primary, secondary, tertiary, and continuing branching has cartilage to help keep those airways open. And so the bronchial tree, I like that name because you think of a tree branch. You've got a branch, and then every successive branch, the branches get smaller and smaller and smaller and smaller and smaller till you get to a leaf. And so what happens now is the bronchial tree is the same thing where you've got this branching, except instead of leaves, you've got the functional part of the respiratory system called the alveoli or alveolar sacs. So the airways are important because we want to make sure that they stay open. Now, one of the ways that we help increase the diameter, and so you may have heard this, the sympathetic nervous system is the fight or flight. And part of it is if you were in a forest and you meet a bear, it's always a bear in physiology textbooks. You have two options. You either fight the bear or you run from the bear. Your body responds the exact same way, whether you fight or flight, that your heart rate goes up, your pupils dilate, you increase blood, and your airways dilate. And part of that is you have an adrenaline rush. So the adrenal medulla, that adrenal gland, is this gland that sits on the top of the kidneys. And the medulla secretes a hormone called epinephrine. And epinephrine binds to receptors that are on our airways, or beta adrenergic receptor. So what happens when epinephrine binds, the airways dilate because the airways are lined with smooth muscle. And smooth muscle is a type of muscle in our body that we do not have conscious control over. Like our biceps, you think, I'm going to bend my elbow, I'm going to flex this muscle. You can consciously do that. But these muscles, the smooth muscles that line your airways or your blood vessels or the uterus or the bladder, we do not have conscious control over. It is under the autonomic nervous system, either sympathetics or parasympathetics. My nose is itchy. I thought I'd share that with you. So what happens when epinephrine binds, the smooth muscle relaxes and these airways dilate. We call that bronchodilation. This becomes very important when you're exercising and you need to increase airway. Now, a problem happens in people who have asthma. Now, asthma is that these airways now are more narrow. And a number of reasons. You've got, usually you have this increase of eosinophils, these type of white blood cells that come in this area. Then you've got edema, where you swelling of the tissues that make the tissues, and the inflammation that make the tissues get bigger, and so the airway gets smaller. The goblet cells make more mucus, and so what we see is these airways, not only that they're more narrow, and then the red is representing this inflammation, the swelling that then makes the airway smaller, and then these goblet cells make more mucus that lines this, and then our vagus nerve makes the smooth muscle constrict. All of those are now setting up a chain of events for a very tough thing. So instead of being like by ratio, looking like a toilet paper roll, it's now a straw. And in really bad cases, it closes off like a coffee straw, almost completely. And so what happens is it makes it very difficult for these individuals to be able to breathe. So one of the ways that medicine helps is they have an inhaler, and in the inhaler is when pump is it sends this medication in there that has a medicine that acts, that looks and acts much like epinephrine does. And what it does is you put a lot of this and it then binds to these same beta receptors, and you have this swelling, a dilation, bronchodilation, to help people with asthma to breathe better. Airways get bigger. All right, so here we have, there's the bronchial tree, and I've taken one airway out. This is what the airway, kind of the cells look like. You have all these cells that are lining this, and some of them have cilia, and the cilia look like these tiny hair-like projections that come around the top. So these ciliated columnar cells move. That's what cilia does. But we also have these goblet cells, and goblet cells make mucus. So what the cilia and the mucus do is they make what's called a mucociliary elevator. That's the actual term that is used. And I'd like to think of it more like a mucociliary escalator in the sense that that the cilia move, so as mucus is made, that the cilia just keep moving mucus along. And what's in this mucus? That's the flypaper. That's what's trapping dust and particles as we inhale. And so that's what's inhibiting or preventing when you walk through a construction site, or you live in an area. I currently live in Utah where it's dry and there's a lot of dust because we live in the desert. That's what gets trapped in this. And then you keep the cilia, keep moving it up, and it's the mover until what? Until you spit that out. And you spit it out, and that's what allows you to, you spit. You expirate that on the ground, and that mucus has a bunch of dust and germs and such in it. All right, so here we have, this is one of my illustrations that show the lungs, and I want to demonstrate how very compartmentalized our lungs are in relation to these bronchial trees. So it's called the right primary bronchus, or right mainstem bronchus, and it supplies the entire right lung. So that concept is very basic, but health-wise and clinically it becomes very important, because if there is, if for example a tumor is surrounding that right mainstem or right primary bronchus and either suffocates, chokes that area, the entire right lung may be healthy, except for the tumor right around that right primary bronchus. But that tumor will block the airway, so now air cannot get in or out, and now the individual is only breathing with one lung. And so it's important to keep all these airways open. The left mainstem bronchus also we see going to the left lung, and so our right and left mainstem bronchi supply the two lungs, right and left lung. And you'll notice the right primary bronchus is a little bit more vertical than the left. And this is why inhaled objects like children that swallow pennies or popcorn kernels, why most of the time that inhaled popcorn kernel will come down the right mainstem bronchus and go down into one of the lower lobes of the lung. All right, so now we have here, these are the secondary bronchi, or also called lobar bronchi, because they supply lobes. The right lung has 3 lobes and the left lung has 2. So you'll notice the superior lobe, middle lobe, and inferior lobe are all supplied by individual lobar bronchi. And it looks like it's in outer space, but we just have to add like the airways that go into it. And then the left lung, superior and inferior lobe. So the secondary bronchi because it's the second branch, or also known as lobar bronchi because they supply the lobes, are shown here. Next are the tertiary bronchi. Primary, first, secondary, second, tertiary, third. These bronchi supply a bronchopulmonary segment. This is why they're also called segmental bronchi. And so all those yellow lines are representing these segmental bronchi, and they supply a part of a lobe. And so coming off, and you'll see that all of those have different names. So bronchopulmonary segments become important because they are surgically a unique set of a lobe, which means its airway and blood supply and lymphatic drainage are packaged. So surgically, a bronchopulmonary segment could be removed. So for example, if there was a tumor, say a Pancoast tumor here in the apical segment of the right lung, that whole apical segment could be surgically removed, leaving the posterior and anterior segments of that one lobe intact. So there we have at the very end, and if we look at the end, if we see like now the trachea is coming down, and then there's the bronchi, and you see the bronchial tree branching, and these cute little things at the end. Those are the alveoli, or the alveolar sacs. This is now the functional part of the respiratory system. Basically, if you think of the trachea and bronchial tree, that entire area is for airway movement, but not gas exchange. So we call that ventilation, and then the respiration, where the actual gas exchange occurs, here is in the alveoli. And so in this schematic, the alveolus is the circle, and then we have a capillary that's coming around the bottom. And whenever you see that word pulmonary, like a pulmonologist or a pulmonary capillary, think lungs. So this is a capillary, a very thin blood vessel that is touching the alveoli. This is the air-blood barrier, or gas-blood barrier. And so you'll notice CO2 in the upper left, because coming into this capillary is blood that the heart is pumping to the lungs, because we need to get rid of carbon dioxide and we need to collect oxygen. So CO2 is for carbon dioxide. It comes in, and then gases diffuse via concentration gradients. And so if you've ever had, like, you come into a room and you spray, you go psst, like something that smells nice. I couldn't think of what, like a Febreze? Is that right? Febreze? And you spray it, and you're standing 4 feet away. Just give it a minute, and it will diffuse, and then you'll be able to smell it. Gas does this. Gas is diffused down the concentration gradients, high to low concentration. So in the pulmonary capillary, carbon dioxide's high in concentration, and then it diffuses across the endothelial membrane and these type 1 pneumocytes of the alveolus into the alveolar capillary. That's what you're going to exhale, okay? Now you inhale oxygen. So oxygen just came in, O2. Now oxygen is in high concentration in the alveolus, but low in the pulmonary capillary, so oxygen diffuses across, and then the pulmonary capillary brings it through the pulmonary veins back to the heart, and the heart, that was me being a heart. The heart pumps blood throughout the body, and those arteries now are rich in oxygen, and the oxygen goes and diffuses into those tissues. So what we see happen is it happens at the exact same time, okay? And the CO2 and O2 and things are inhaling and exhaling happening at the same time. So here's a healthy individual. So you can see, instead of just one alveolus, there's an alveolar sac, and you can see the blood vessels. So in blue, you get an idea of carbon dioxide diffusing into the alveolar sacs, and you exhale it, in red showing oxygen coming in, and that's when things are hunky-dory. Things are good. But what happens when it's not? So for example, in pneumonia can either be from a virus or a bacteria. This infection causes many things, and one of them is goblet cells become very sensitized and they hypersecrete mucus. And look, so the airway is clear, now the airway is filled with mucus. Now look, it is hard for oxygen to get in or CO2 to get out. So in really severe cases of pneumonia, one of the challenges is that it is hard to breathe. Now, what do you do if someone has a bacterial infection? You go to the doctor and the doctor says, oh, you got a bacterial infection. Take this antibiotic. Take it just as instructed. In a few days, you'll start feeling better. Make sure you take it all the way to the end. The challenge that can happen with pneumonia is it's hard for the medicine to get into all the germs, because this is where your antibiotic comes in. You swallow it in your mouth and then the bloodstream reabsorbs it from your intestines. It is hard to get to all these areas. Now, it's not impossible, but it is hard. And this is why people in severe cases of pneumonia think what happened during COVID, where you have people that are on ventilators, because COVID resulted in such a bad infection in the lungs like this, that air couldn't get in and the medications couldn't get in. So you're trying to help give them antibiotics to give the body time to fight this infection. And then you're forcing air into their lungs to try to help this patient to be able to breathe, hoping that they'll overcome the infection in time. So here's an example. This is a chest x-ray. And a chest x-ray is you radiate, you put x-rays through someone's chest. And there's a film at the back that is exposed. And so whenever you look at a chest x-ray, if something is not dense, think air, it appears black. If something is very dense, think bone, it appears bright. And then between, we have these different shades of gray depending on density. And so in this picture, you can see this dark area here. These are your lungs. It's filled with air. That's why it appears almost black. And then you see these outlines. There's the collarbone, the clavicle, and there's the scapula. And each of these is showing ribs because they're bone. That's why they're hard. And then you see this dome shape, and that's the diaphragm, and there's the heart shadow. And notice this is all clear and all clear. And then we have this wedge shape right there, okay? And there we have lobar pneumonia. And that white is showing some type of consolidation, probably mucus, that's in this area, where that's one way you can tell pneumonia is you just got it's usually localized to a lobe. They're just filled with this gunk, making it very hard to breathe. Now, this individual looks like they have their upper and middle lobes still intact, but their left lobe intact. So they might not have too much trouble breathing, but this is why when you go to see a doctor and they do oxygen sats and they're like, hey, we just want to make sure that when they are measuring the oxygen, they usually stick that little sensor on your finger, and it's got like these lasers that go through, and it's sensing the amount of oxygen, and we want to make sure that that is always above 90%. If it drops below 90%, they usually then start giving you nasal cannula of oxygen to help make sure you're getting enough oxygen to the body. So another example. So here we've got, in this illustration, this is a relatively healthy individual. There's the lung, and then this pullout, we can see these alveolar sacs. And you take a look, it kind of looks like a honeycomb, eh? And it's a cross-section of the lungs, and you need all of these different circles, I'll call them circles, these alveoli, because they then connect with the arteries. And that's where the gas exchange occurs. So the problem is in cases of COPD, emphysema, is that those air spaces break down, and they now, instead of having really small rooms, you've got big rooms. And the problem with having, instead of say 100 small rooms and instead having 30 bigger rooms, is we've lost the walls that separate the rooms. And when you lose the walls, you lose that interface with the capillaries, and now it is harder to have gas exchange. And that's why individuals who have COPD, and usually a number of things can cause COPD, smoking is one of the biggest ones, is that you'll often see them on oxygen. And they need to be on oxygen because their body is not able to get their oxygen sats over 90%. And so they're now on nasal. It's usually nasal, and they'll carry around an oxygen container or canister to help make sure their body's getting the amount of oxygen they need. And so this is showing a gross, not gross like ew, even though you might think that. Gross pathology means pathology you can see with the eye without the aid of a microscope. So this gross pathological section shows that is what healthy lungs should look like. Look at this lung. look at the size of those alveolar spaces and the reduction that happens in gas exchange. So those who recognize Spock or Leonard Nimoy, he smoked a lot in the beginning of his life, and so that's one of the big things that he struggled with later on in life was COPD and chronic obstructive pulmonary disorder. That's what it stands for. Emphysema is the challenge. All right. Lungs, that's what I've got here. Okay, so surrounding the lungs. So something that I did before with regards to showing these organs that move a lot is that we want to make sure that friction doesn't build up. So if you do this with your hands just a couple of times, you feel heat build up. And that heat is because of friction. So every time we inhale and exhale, you see the ribs moving. And inside the ribs are the lungs. That's what they're adhered to. And so to help make sure we don't get friction buildup, the lungs are surrounded by these two sacs for each lungs called the pleural sacs, or just the pleura. And in this coronal section, this illustration that I did, there in blue is shown the parietal pleura. Parietal means wall. That's the pleural membrane that is adhered to the inside of the rib cage. And then in orange, that's the visceral pleura. Visceral means organ. It's the membrane that's lining the that's touching. It's like vacuum sealed on the lung itself. And between the two is this tiny space called the pleural space that's filled with fluids. We call it pleural fluid. And then these areas like down at the bottom that there's these openings called the costophrenic or costodiaphragmatic recess that allows for expansion of the lung. Now that pleural space is in that whole area. So when you inhale, what happens is the lung can go down to that costophrenic space, but that pleural fluid in that space has a negative pressure that helps keep the lungs inflated. Now, moving the lungs. How do we make the lungs bigger? So the diaphragm muscle is what does that. And so at the top, I show, you can see a posterior view of the skull and the spinal cord in the vertebral column, and the letters C3, C4, and C5 represent three important levels of the spinal cord, because coming off of each of those levels are nerves called the phrenic nerve bilaterally that are like suspenders that come down to the diaphragm. I mention the spinal cord levels because spinal cord injuries are problematic for a variety of reasons. The spinal cord has north-going and south-going neurons that go from the brain to muscles and organs, and from skin and muscles and organs to the brain. If you have a spinal cord injury and you break the pathways, the brain can no longer communicate with the body and vice versa. So when you hear people say they got a broken back or a broken spine and now they're paralyzed, what that's meaning is, say a cervical vertebra fractured and hit. Think of Christopher Reeve, the Superman. He's the Superman that I remember when I was a child. He fell off a horse and he had a fractured C2 vertebra that fractured and injured his C2 spinal cord level. And as a result, his brain could not communicate efficiently enough or well enough with the levels below, and he couldn't breathe anymore. So not only could he not move or sense anything, he couldn't breathe on his own, and that's why he needed to be on a ventilator the rest of his life. And so when you see that this phrenic nerve comes down, it innervates this diaphragm muscle. And so the diaphragm contracts or it relaxes. Contracts or relaxes. Now watch when it contracts. So those white arrows I drew, so in orange is showing our two lungs. Now watch, you see the blue thing of the diaphragm? That's relaxed, because what happens when the diaphragm contracts, it pulls down. And then it relaxes, it goes back up to a dome shape, and it contracts, it pulls down. Now watch what happens to the thoracic volume. When the diaphragm contracts, you see that? Thoracic volume increases. Relax, contracts. Relaxes. And so the lungs are adhered to the top of the diaphragm. So whatever the diaphragm does, and when the lungs get bigger, the volume within these alveolar sacs increases, which means its pressure drops and it sucks or draws air in. All right. Now, what are hiccups? We all know what hiccups are. The interesting thing about hiccups is we don't really know. We kind of know, but don't really know why they happen and how they start or stop. But we do know that hiccups are an irritation of the phrenic nerve that shoots an action potential down the phrenic nerve that causes the synapse with the muscles in the diaphragm, and the diaphragm does this very quick contraction. And it forces this bunch of air up, and that glottis, the vocal folds, go, and that sound is basically the movement of the vocal folds as this very quick burst of air comes up. And every family's got it. So my wife, Celine, her favorite thing is to say, all right, if you get hiccups, take a teaspoon of sugar and swallow it. Or close this and swallow 20 times. And then there's other ones that say, drink from a glass upside down. Every one of these, none of them work. None of them have a scientific basis to show that they work. However, I do them every time when I get hiccups because it's a pain in the neck. But that's an irritation of the phrenic nerve. That's what hiccups. If you're thinking I'm going to tell you how to stop it, I don't actually have a good reason, and neither does science. Now, a cough, I initiated this and talked about it before. A cough is our body's way of getting stuff out. So one of the reasons, for example, you take a look at people who smoke, and they will cough a lot. You remember the cilia that I talked about that lines our airways? Well, smoking reduces the motility of those cilia. So those movements of the cilia, that mucociliary elevator, the cilia don't move a lot or at all. And goblet cells become sensitized from the toxins of the cigarette smoke, so they start making more mucus. So you have this problem, and that is mucus is good. We're supposed to have mucus lining the airway. That's one of the ways we keep our airways clean and stop gunk from getting down to the alveolar sacs. But if you smoke, what happens is you reduce the motility of the cilia. Goblet cells make a lot more mucus, so the only way to get the mucus out is to cough. And that's when you hear of the smoker's cough, which is they start coughing, and it's almost like a crescendo trying to get that mucus out of the body. It is nature's way of getting it out. And that's why when people have like the common cold or the flu, that it's often associated with sneezing and coughing, because it is nature's way of getting stuff out. And so sneezing, the same thing. You've got stuff in the airways and to get it out, but sneezing is even more forceful. Now, this lipid droplet picture, I know it's not like the most pleasant thing to look at, but during COVID and the height of COVID and people started wearing masks, this is why we wear masks. Because what happens is you see each of these droplets, it has you hear about people talking about shedding the virus, because the virus is in these particles of our saliva. So when we sneeze, think of these particles housing these elements of the virus. Now, what a mask does, and people are like, I've heard a lot of people say, oh, the mask doesn't stop those viruses from getting through because the viruses are too small. Oh, that's true. But what happens is when you wear a mask is you reduce this spray, and now the spray instead stays closer to the individual. This is also why when you sneeze, they say sneeze in your elbow, because it's stopping this. Like, just think of a spray bottle going, and that spray bottle just goes everywhere. That's a sneeze. Now take a spray bottle and put your hand in front of it and squeeze it. Some still gets around, but it blocks the amount that occurs and goes out. So, in conclusion, we should take care of our lungs. There's a reason that there's elements of the word of wisdom that talk about to not use tobacco. Now, that's whether it's cigarette smoke and inhaling or vaping. Vaping is an epidemic that's going right across North America and across the world. And still, pulmonologists are finding different ways that vaping causes insults to the lung and problems to the lung health. And so nicotine, regardless of how it is brought into the body, is also habit forming. So don't smoke. Don't do drugs. Stay in school. All those things. But take care of your lungs, because as we age, there's a few things that we should all keep in mind. One, keep our muscles strong. That doesn't mean you have to be a bodybuilder, but do resistance training. Continue to try to be flexible. This is what allows you to get in and out of chairs and in and out of bed and so forth. Keep your heart healthy. Do 30 to 60 minutes of moderate to more extreme exercise a day, 5 days a week, because that helps your heart and it helps your lungs. When you have like inversion that you see or smog on the really bad smoggy days, stay inside if you're able to. That alone helps to stop the irritation that occurs with the respiratory system. So respiratory system is one of those very cool, one of the many organ systems of the body that we might not think about, but it is essential for our life. Yeah, that's all I have to say about respiratory system today. Thank you.